Welcome to the Caregiver Relief Podcast. I'm your host, Diane Carbo, RN, and today we are addressing a growing emergency that touches every corner of our healthcare system, from agencies and providers to families and caregivers who hold it all together. While the current government shutdown has captured national attention for its immediate impact on Medicaid, Medicare, and Social Security reimbursements, the truth is this crisis didn't start last week. It's been building for years. We are facing an ongoing collapse of home care fueled by Medicare, lowered reimbursement rates, and the spread of Medicare Advantage plans that have quietly shifted to cost-sharing model. That means patients, many on fixed incomes, are now being told they must pay for recommended treatments, services, and therapies themselves or go without. And Medicaid has cut reimbursement to unsustainable levels. As a result, more and more families are being forced to step in and provide services that were once handled by trained healthcare professionals. The burden of care is no longer shared by the system, it's being transferred to the family caregiver. Recent statistics reveal the staggering scope of this hidden crisis. Family caregivers now provide an estimated $1 trillion in unpaid care each year. That astonished me because that is a new stat out there. Yeah. $1 trillion of time, energy, and sacrifice, all while many of the same caregivers struggle to support and survive on low wages, shrinking support programs like SNAP, which are now at risk during the ongoing shutdown. Family caregivers have no affordable respite care available and depend on home care services to support them as much as they can. Joining me today is Aria Rashidian from Aria Home Healthcare, one of North Virginia's most trusted home health agencies. Aria has his hand on the pulse of what's really happening in home care, from Medicaid reimbursement cuts and Medicare Advantage organization administrative barriers to the daily challenges of recruiting and retaining caregivers who are essential to keeping vulnerable Americans safe at home. Together, we'll unpack how policy failures and underfunding are pushing our home care system and the families who depend on it to the breaking point and what must change to protect the people who give and receive their care every day. This episode is sponsored by myvitalvault.net, your all-in-one life organizer for aging adults and caregivers. It's designed to help you securely store your essential legal, medical, and emergency information in one easy-to-access place. Because when a crisis hits, being prepared can make all the difference. Join our Caregiver Relief community, a warm, welcoming space where you can connect with other caregivers, ask questions, share stories, and find support from people who truly understand. Visit community.caregiverrelief.com to join now, because caregiving is one of the hardest and most meaningful things you'll ever do, and no one should have to do it alone. And if this episode speaks to you, please take a moment to like, share, or comment. Every click helps us reach more caregivers who need encouragement, resources, and hope. Aria, thank you so much for joining me today. I'm glad you reached out to me. But before we dive in, can you tell our listeners a bit about the Aria Home Healthcare and what inspired your mission to provide compassionate, affordable in-home care in Northern Virginia?
So, yes, thank you for that lovely introduction, Diane. Hi, all. Again, my name is Aria. I'm the alternate administrator of Aria Home Healthcare. Originally, the agency was founded by Ms. Mojgan Purakbar, who's had over 37 years of nursing experience, working in various facets, including inpatient hospital settings to outpatient care to even home health care herself. And she really wanted to design an agency that really delivers that reliable senior home care services with really experienced and supportive caregivers who truly feel like family through the interactions and obviously their skill training. So because we noticed that this was an industry that needed the most amount of care, and given those alarming statistics, this industry is scheduled to grow more and more each and every year. One of the things we really want to do, and really our biggest selling point, is that we aim to build trust with the caregivers, with the family members, and the clients, because it's truly a three-way street. So we like to think that we are very unique in that standard, because a lot of agencies either just coordinate with one or the other, or they just coordinate not well at all, as we probably have
I
seen
can
and
attest
heard.
to that. Yes.
And we just want to make sure that we're there, whatever you need in terms of palliative care, private duty nursing, home health, and personal care, we'll be there to assist you.
All right, for those listening who may not be familiar, can you define the different types of home care services, from personal care, skilled care, palliative care, and explain how they're funded through Medicaid, Medicare, private pay, or insurance?
So that's a wonderful question, and hopefully we'll have enough time. So again, nursing, skilled care usually falls within the facet of Medicare, Medicaid, and also privately paid. Obviously, skilled includes occupational therapy, which includes aspects that you need with a licensed therapist to do your everyday tasks. Much different than personal care, because obviously it's more medically involved, learning to walk, learning to eat, and all of those things. There's also physical therapy that you need to, which is under a facet of skilled nursing care. There's IV therapy, there's wound care, and these are aspects that are mostly covered by Medicare and through private pay. They are not aspects that are covered mostly by Medicaid. It depends on certain waivers that you get, because even though Medicare and Medicaid are federal programs, they do have state components. And also, likewise, MCO, managed care organizations such as Anthem, Aetna, United Healthcare, etc., these also have their own administrative needs in order to qualify for those state waiver programs. As Medicaid is federal and state funded, although that is scheduled to change in the coming years, given through the passage of the One Big Beautiful Bill that passed in July. But right now, they are considered, just like Medicare, mandatory spending. They are, however, being reduced, and the waivers are being a little bit more difficult to apply and receive, although they are still being offered as of now. Now, in terms of personal care, usually a service that's offered by Medicaid, mostly through its, again, waiver process, and they're still eligible right now, although, again, eligibility is becoming more stringent through the bureaucratic process and bureaucratic pressures. And it's also privately funded. You can also apply for it private pay. Palliative care is a little bit more specialized, and it is usually done by a nurse, and it is Medicare funded. It is not something that is offered by Medicaid. And it is very important that you understand the specific kind of needs that your loved one wants. And then once you talk with your insurance carrier and you understand, the process, then you can reach out to the appropriate home health care agencies like us to go ahead and help you with that.
Does Virginia pay family caregivers to provide care in the home under Medicaid?
They do. There's agency-directed services, and then there's consumer-directed services, A, D, and CD. Now, CDs, obviously, the rates of reimbursements often differ from agency-directed services, because obviously agencies carry more of the burden and the hiring process and administrative responsibilities. Consumer-directed pretty much relies on the person, and they get paid the same way, even if it was under an agency-directed care, but they will be responsible for more of the maintenance of the client, as well as management of the conditions and communicating with the state agencies. Versus agency-directed services, we obviously do all the legwork, application process, and renewals and recertifications, and usually coordinate well with the case managers.
Because right now, not every state provides that benefit through Medicaid. So I wanted to make sure that people are aware that while we are talking about what's going on in Virginia, this is something that's actually the process and the problems are rampant throughout the whole country. Now, I'd like to address how current Medicaid and managed care organization reimbursement rates affect your ability to recruit and retain qualified caregivers while maintaining quality and continuity of care.
That's a fantastic question. Unfortunately, quality and care all relate to funding. And especially the more funding we have, the better we can be in making sure we get the absolute best caregivers and trained personnel or even nurses as possible. But as this bill is being passed, we may see a little bit of a shift in losing potential additional state funding because, as I mentioned before, it is federal and it is state. And if the state isn't able to raise its taxes enough to meet the federal level, and it's only the federal percentage, then we may see a cut of maybe upwards of 50% and in the rates. And if that happens with the already low rate that we get, and unfortunately, it's different all around. Northern Virginia rates are higher because it's associated with a higher cost of living, more urbanized area than Central Virginia and obviously rural Virginia. So the rates are different all around, but the cuts are going to affect all three of those rates regardless.
I think these cuts are going to continue on for a very long time because what we have is a situation where we have more seniors than youth, and each generation on from the millennials on and baby boomers on down, we have not replaced our youth, our own population. So we're getting fewer and fewer workers, and the ability to the youth of our country are our workforce. They are our tax base. And I'm seeing with the growing population, and this is going to go on for decades, that we're going to have issues with, we're going to have to pay higher taxes in order to provide care, at least any kind of care, just not even just quality care to our elderly, our disabled, our veterans even. Absolutely. And that's the challenge you're dealing with right now is, I think right now, I feel, and you can correct me if I'm wrong, we're at a critical mass. This is hit to the point where agencies are closing, hospitals are closing. It's very frightening. And as you were saying, the rural communities are struggling because they have less ability to attract help than you in an urban area.
Yeah, it's certainly, I know for a fact that rural areas, especially in Virginia, if this continues and no amendments are passed, I know that rural Virginians will not get access to quality Medicaid services or access to providers that accept Medicaid because the cost of doing business has gone so high for them. And this includes payroll, this includes vendors, and whether they are experiencing tariffs or not, the vendors, they put that cost on the businesses. And usually if they are not a non-for-profit corporation, they are a for-profit corporation, then they are not going to see the need of servicing those areas. So in a way, they will close down. It's not a matter of if, it's a matter of when.
Absolutely.
The way things are going right now, even in urban areas where we have a higher cost, obviously in terms of, again, our vendors and with the way we're positioned in the marketplace and obviously labor costs. It is going to be significantly harder for even us to operate, much less than even a smaller home care provider in the region starting out.
I want you to give us a look in what's happening in the specific challenges you face dealing with the electronic visit verification compliance, a government loophole you have to pass or you don't get paid, data reporting requirements and billing processes that occur under today's managed care organizations this also applies to Medicaid because they're mostly managed care organizations as well.
Yes. So again, excellent segue. So EVV stands for electronic visit verification, and it is a mechanism used to report visits conducted, usually for personal care, private duty nursing services, and most services that fall under the purview of receiving Medicaid funding. And it is a way, and it was passed through the Infrastructure Act that was under President Biden. And this allowed for agencies to be more compliant and for MCOs, the managed care organizations, to be able to track visit progress and see visits being performed. Because prior to 2020, visits were conducted with a piece of paper. And as shocking as that sounds, since really Medicaid has been paying for these kinds of waiver services, as we now call them, like personal care, private duty nursing, not palliative care, private duty nursing, and home health, certain home health services, since 1974, they've been really done by paper. And pretty much how that works is they will get a piece of paper that's designated by the state. The caregiver fills it out week by week, and every single day gets it signed by the patient, gets it signed by themselves and the nurse. And while that was the common ground, it's still very little still the common ground today. Very rarely. They're starting to phase that out. In fact, I believe by the end of this year or next, completely, is that has become a breeding ground for fraud. A lot of times care wasn't being rendered, it wasn't being administered correctly, and it has
Absolutely.
resulted to the federal government trying to take action along with state agencies to try and mitigate fraud. That's why they have an EVV system, which is basically like a clock in, clock out timesheet that's GPS enabled. So they can know that the care is being coordinated at the place of residence, that's verified by Medicaid, and along with other administrative requirements that they have agencies going through. And I believe that this has the potential to hone in caregivers, hone in the agencies, and ultimately deliver a better quality of care than probably what was before.
That's impressive.
Yeah.
I have done home care,
Yeah.
and what I'm seeing now are more unsafe discharges to home than ever before because Medicare Advantage and Medicare reimbursement for skilled care and nursing homes and rehab have been so low that they get a higher level of reimbursement not to provide therapy. So what's happening is we're seeing a high amount of unsafe discharges to home, and it's been horrendous. I can't even begin to tell you what I'm seeing, which I know you must be seeing as well. And what I'm seeing, I'd like to learn more about the data reporting requirements that you do, because I see therapists coming in from home care and they're not doing much, or nurses aren't coming in like they should be to see the patient. And I'd like to explain what that has to do with the reimbursement and why these services aren't being provided.
Well, it's not necessarily they're not being provided, another excellent segue, but the reason they're not being provided probably in a way that we expect is because behaviors have changed, attitudes have changed, but also because of the fact that this has become a volume-based business. So that means that they have to see a lot of clients. They get paid per visit. They don't get paid an hourly rate. They don't get paid in a half-hour rate or some other ambiguous payment model. They get paid per visit. So per visit could be anywhere from $20 to $50 to $100 to even $200 at the very highest. So that means in order to make ends meet, they do have to go in a cyclical fashion. They do have to go from client to client and hoping in those times that they spend with the client, they are providing the best care possible through their training, through the company procedures and policy, and ultimately through their own personal willingness. Because a lot of times you could have the best care, best training, best environment, and the person will still act in a way that goes against all of those. And that really all depends on the person, on their behavior, their attitudes, and ultimately what they're going through. Again, we have to understand that these are people too. They have their own personal lives, and sometimes it's not positive for them. And especially if they're only getting paid anywhere from $50 to $100 a visit, and that visit could last anywhere from 1 to 2 hours, even 3 sometimes, because of the fact that they have so much work involved with that one patient and what they
Yes.
have to do. It's very unfair to them because they're not being paid what they are owed. And they could be doing much better working in another industry or another facility altogether. Our fight is to retain quality people, is to care for these, whether they be caregivers, whether they be nurses, whether they be PT, OT specialists, is to really care for them, but also at the same time, make sure that they are providing those services and they are there for that fair period of time and they are providing that quality care. So again, as I mentioned, it's always a three-way street. In this case, it's a two-way street, right? You have to make sure your staff is being taken care of and as well as the client.
Yeah.
And sometimes if the client can't speak English or isn't able to communicate, then the family member, then it becomes a three-way street. You have to make sure that all the parties are informed about the kind of care that they're receiving beforehand. And if an incident like that does happen, the agency has to be prepared to communicate to make sure that those concerns are being addressed so the care can still continue.
All the government regulations and loopholes have destroyed our health care. I can tell you that I've been a nurse for 50 years and I've worked on both sides of the fence. In fact, I worked for, now this is 45 years ago in Minnesota, the very first private review organization that utilized private third-party, they use third-party administrators. Big companies pay for their own healthcare insurance and they manage it oftentimes, and they're allowed to have benefits that go against what they're saying if you ask for it in a right way. And what we were doing is, I'll tell you what, this is something I'll share with you. 45 years ago, people in New York, if they wanted a bed in the hospital, were admitted to the hospital 2 days before procedures were done to have all their pre-op testing done. Isn't that astonishing?
Yeah,
and home care was very, very, very lucrative and it was very available. But now you have administrative burdens and there's reimbursement delays are impacted by billing inefficiency, staff morale, and client satisfaction. Can you address that a little bit?
Absolutely. And really how it's affecting staff is that right now, as we're in this government shutdown, it is going to affect especially the caregivers, which even though they are specialized, it is part of the lower reimbursement model of care, very volume-based in terms of the number of hours they have to spend with the patient. The reimbursement model is rather low, requiring them to rely on SNAP and other federal subsidized program and state subsidized program to make sure that their needs or their quality of life is being met, especially in a very urban area, because there's only so much that the agencies can provide to their staff and still be able to operate in an efficient manner, that these considerations also have to be taken in. And it's very tough. We don't know how long this will last and also how it's going to truly impact the staff until obviously it has taken effect, and then we can understand. But obviously we hope that this issue can be averted and government can be opened so this critical supplement can be used to offset any kind of cost that these caregivers will incur in addition to working.
Well,
and providing that quality of care.
Yes. And I could tell you, even with when the government opens, this is something we have really got to address. The advent of Obamacare destroyed our healthcare system. Our private insurance companies I'll talk in the olden days, were able to provide enough revenue for the home care companies and the hospitals to take on and provide a lot of free care. And I always was proud of being a nurse and seeing how our health care system worked, because anybody on Medicaid that was in a teaching hospital got the same care level that a person that had the best health care insurance in the world. And they were treated. And it was when they went home that it became a challenge, because depending on their benefits, those with private insurance had amazing home care benefits. Those with Medicaid were always a challenge. It's been going on for decades because I can tell you right now, I worked with the visiting nurses of Greater Philadelphia. I was a liaison. So I went around to all the hospitals in the area looking for people that patients that were going to need home care. And when it came to Medicaid or Medicare Advantage, the VNA did not want to accept those patients. And if they did, they only did it for one visit, which broke my heart. But those with Medicaid have always struggled. They don't get the equipment they need. They don't get the healthcare follow-ups they need. They just don't get it. And they haven't and I can tell you that was 30 years ago. So this is ongoing, but now we have a crisis because now the Medicare Advantage plans are also paying a very low reimbursement rate. And in the past, in the olden days, we were able to take the patient's Medicare Advantage and transfer it back to traditional Medicare, where the reimbursement rate was higher and they were able to get a better quality of service. But our government involvement has changed that now. Last year, they made it so that if you had been on a Medicare Advantage program 11 months and so many days, you can never go back to traditional Medicare. And the reason for that is they want to move all Medicare to a cost-sharing plan. So government involvement has done nothing to improve our quality of healthcare. In fact, it's brought it down, and it's done nothing to lower costs. In fact, it's quite the opposite. It's because it's created no competition in all these states with these managed care plans. What it's done is allowed prices to soar. So we really have to we need our whole system revamped to take over what's happening, because we are, like I say, I believe, at critical mass. So we are in the middle of this government shutdown. So how is it affecting the Medicaid and Medicare reimbursement timelines for providers like you?
So it has, in a way, created a lot of significant challenges. As you mentioned, it's not easy for a lot of home care providers to be able to mitigate through this without necessary funding. We can point fingers whether we can say, oh, it was the politicians or particular people that were responsible for this, but all in all, this was something that the government had in mind during the Bush administration towards the end, where they wanted to create a kind of similar, we're not going to call it Obamacare, but like a national health care plan. But it was only when President Barack Obama won the election that the parties decided to shift gears and make it a little bit harder, because even the politicians themselves, they want to make everything a partisan issue, and they don't really care about the quality and the life of
I agree 100%.
because they receive the top healthcare in the world.
Yes.
They receive everything, so they don't really have any entitlement. And because the baby boomer is slowly dying off, which was mainly their voting base, and the younger generation will continue to not really vote or be as proactive as the baby boomer generation. It's enabled those those individuals in power to find ways to mitigate, to cut costs. Because again, what leaves out of one pocket must go and fill the other pocket. So something is cut, it allows for corporations, for wealthy individuals to take advantage of the tax system, to pay lesser taxes, because it has to fund something. So if you're going to fund their lifestyle, then something has to be cut. And something as considered mandatory spending is one of the biggest issues of government, because they consider that as a luxury. Same with Social Security, same thing with Medicare, Medicaid, that these shouldn't be services that the government should pay for, should be something that should be at the leisure of states and other private individuals. While it may sound ideal, we have to understand human nature, and we have to understand people, and we have to understand that it's only great if everything is going great for them or great for the state. There's
Well,
tax.
our present medical delivery system mirrors the military delivery system, and that's all that they're. I know both very well, and that the government ran the VA, the active military, and the veterans system, and that's what we mirror now. And it's really sad because both are offer. Right now, we're just providing band-aids to people sometimes, and it's just not enough.
Yeah. But I feel like that's how we've always been doing it. Since this program came in place, since these waiver services first became available back in 1974, and really through the Medicare introduction and Medicaid introduction in 1965, government has not really been paying attention to the problem, but rather letting it balloon just like everything else.
I agree 100%. Yes.
Yeah. So
now you're seeing on the ground as the shutdown drags. What are you seeing on the ground as this shutdown drags on, particularly for your caregivers who depend on SNAP benefits or other supplemental income to make ends? And I want our listeners to know that the majority of the caregivers out there, the professional caregivers, oftentimes live at or below poverty level because of the wages they're provided, and many of them hold 2 or 3 jobs at a time to make ends meet.
So what we try and do is we try and provide consistent care. We try and have them be usually with one, no more than 2 clients, and we try and give them as many hours as possible, contingent on the patient's condition. Because we don't want them doing all of that. We don't want them holding 2 or 3 jobs. We want to help them out as much as possible, but at the same time, we have to make sure that we are operating in an efficient model. Now, home cares aren't the only ones impacted by this. You will be surprised if I tell you a lot of Walmart and large retailers often have employees that are very reliant on SNAP and other benefits to make their ends meet, especially in rural America where they don't have a lot of shoppers. A lot of these chains will often underpay their workers 100%. As a result of lower sales. And that's just capitalism. So in a way, it's not only affecting us, but it's affecting everyone. And I think the matter is only going to get worse with lower tax revenue being able to offset or help assist with the cost of increasing payment to the providers who are providing these services, because it's very unfair if our nurses have to complete evaluation for clients every 6 months to 1 year and additional compliance measures set by the MCOs and the state. And they also have to make sure that they recruit, train, and staff caregivers, and that they do marketing. All that's based on the simple revenue reimbursement they get from the government, because the government does not pay nurses to do follow-ups or to do enrollments for newly admitted Medicaid clients. They only pay for the caregiver or the nurses being used to service it. So in a way, you have to think the salaries. How much are those managers making? Myself included. How much are they actually making? Because it's all based on that reimbursement. And now that all of these employees are W-2s, and state also has a requirement that if you're over 25, at least in Virginia, if you have over 25 plus employees, you have to offer a 401k plan, add to the administrative cost. And if you're over 50, you have to offer health care. It is a challenge.
Aria, is the nurse not getting reimbursed for opening a case or following up? Like a nurse is always supposed to be following up.
Yes. So again, no, they do not get reimbursed.
No wonder we're not getting, because I've had patients that had new seizure medications, had histories of UTIs, and I'm not seeing cases opened by nurses anymore. And it just was
this only correlates with home care industries. I'm not sure of the outpatient.
I'm just talking about home care. Talking about. No, just home care. Because I'm seeing a lack of use of nurses. And I was like really astonished by that, because nurses are the ones to educate and to assess. So I'm just really shocked by that.
It's very shocking. It's a very underscored thing that's not very much spoken in healthcare, because Yes, the caregivers get paid. The agency gets reimbursed for the caregiver being sent out, or for if it's a private duty nursing, for that nurse to go. But for the nurse who has to do the assessment, for the agency owner, or for anyone
Yeah.
else that's not even a nurse, they do
Yeah.
not get paid. They get paid from the reimbursement or whatever is left after paying down all the expenses,
Oh my
all the
Lord.
taxes, which again would surprise you. So again, the people who are supposed to be in this industry, to conclude, the only people who should be in this industry are the people who want to make a change, not for people who are in it for the business model or for
Yes.
the entrepreneurial mindset, because this is not the business for them, right? This is
No.
the business for people who are dedicated, who are committed to building and in maintaining, right? The key word is maintaining quality of life, because right
Yes.
now we're in the risk of getting that maintenance, breaking that maintenance curve,
Yes.
which
Yes.
is scary.
And what I'm seeing is financial pressures are trickling down to families and care recipients, especially those already struggling to afford private pay care or facing reduced Medicaid coverage. I'm seeing that caregivers are providing so much care and their stress levels, they have lack of affordable respite care. So a lot is falling on the family caregiver. And how are families addressing this, or how are they taking that? And what does that mean for access to care?
So basically, what it means is that they getting access to care usually means the state. And through this, making sure that it's not discriminating, right? Because the state and the MCOs have to go through a simple model, just making sure that they are not being discriminated against. They are making sure that care is being available through any means, electronically, fax, phone lines, etc. That's really what they mean. They don't really mean access to care in terms of receiving the quality care or actually receiving what you are entitled to in some cases, the actual treatment. They don't extend to that. They just mean access to care in terms of having avenues of receiving the care potentially. But the terms of the quality that you receive and the terms of the actual care that does occur, that's not included in that term. It's just, I don't want to say, but it's like almost a feel good term to make sure
Yeah.
that the payers, and in this payers are MCOs, or in the state, reassures people that, hey, if you go with this model, you enroll in this program, you do get access to a lot of benefits. And through this avenue that we have a patient bill of rights, as they'll call it.
Yes. The
That access
deceiving
to care builds into that model.
the deceiving thing is that the high copays and high deductibles for families is beyond affordable. And that's putting caregivers are being forced to fill the gaps when agencies can't get reimbursed, or even now when programs stall due to federal delays. How are you seeing any response to the family caregivers out there and what they're feeling and what they're saying?
No, not right now. Again,
Okay.
thankfully, Medicaid, Medicare, and Social Security are considered mandatory spending now. If this shutdown were to continue, it's very unlikely, but if this shutdown were to continue and extend until November 30th, we could see a lot of delays being with the funds.
Oh
Because
my
if as
Lord, that would be
states,
awful.
yes, because even though they are federally considered mandatory spending, the state could have administrative delays because it could seep into their tax revenue and it could delay some of their other projects. So that will involve having the payments be delayed. Right now, they haven't really done anything about the payments being delayed, but I do know there are some payers out there that are now, for some reasons, actually starting in late September, starting new administrative requirements with military time, because now they are trying to go outside of the COVID model, which was of courtesy, and now really trying to enforce all the EVV aspects into their system, which is not giving enough time to the EVV companies, which are supposed to make those changes to make sure that the providers then send those payments correctly and get reimbursed for their services. So while that's going on with certain payers, a lot of home cares have to rely on loans, on getting cash reserves to make sure that their payrolls are being met and their vendors are being paid, and making sure that they can remain afloat. And I don't think that's a possibility with very small agencies.
It's going to get very dark and very ugly. Even when the government it does start funding, things have got to change because we have a public health crisis right now with the way things are going. Now, Aria, from your vantage point, what policy changes or reforms could help stabilize the home care industry and support both the caregiving workforce and the families who depend on them?
Definitely one thing that could be changed is making sure that there is a more efficient way of, again, unfortunately, one of my studies was in policy. And we just have to find a more efficient reimbursement model. Obviously, the volume of care model is not working, or excuse me, the well-known fee-for-service model is not working. And there has to be a little bit more efficiency of care. But I feel like the only way providers of any kind, small, medium, or large, will only be able to support the model if it supports them as well. So making sure that their reimbursements are timely, making sure that the insurance company is okay, the MCO is okay with paying them this much because their costs are going up. And really that's what's affecting healthcare costs, is because really the specialists are increasing their costs. And as a result, the insurance has to increase its cost to offset the cost brought on by the specialists, the providers, etc. Because again, oftentimes clients that do have Medicare or Medicaid, they pay very low or no premiums at all and receiving all of that care. And all of those MRIs, CT scans, CAT scans, any kind of scans, and also any kind of specialist appointment, specialist office visit, and blood works and lab work is very expensive. And if though they are using those, they have to offset the cost by putting it on the people who actually pay for healthcare.
Yeah, and that's exactly what we're seeing. Yeah,
And
exactly what we're seeing.
because they are using more of the outpatient and inpatient, which is understandable because seniors require more care because they oftentimes in America, they live alone. They don't live with family. So they have to make those costs and set those costs to go ahead and get the care and treatment that they need so they can continue living life. So it's really just a business model. It's an unfortunate model, but I don't think that politicians can fix it because right now politicians are fixated on partisanship, which is making sure that I get one thing I want, I win, you get one thing you want, you win, I lose.
The perfect example.
Win-lose mindset is not going to fix the problem. And unfortunately, we're not in the point where we can have bipartisanship anymore. We just have
we didn't have it when Obamacare was initiated. Nancy Pelosi presented to this 800 or 3,000 page document and said, vote it in and then read what's in it. And there was never allowed, and shame on them all, all of them and everybody, both parties. I don't care. They didn't look at it. They didn't investigate it and explore, and they voted for something they didn't know how it would work out. And it's been a failure as far as lowering costs. And that's the problem. But what people don't understand is Medicare has moved and is pushing everybody. Traditional Medicare is going to be moved out. We're all going to be forced into a managed care program where right now we're seeing the high deductibles, $35 or $40 copay for physical therapy, or $200 to $500 a day in skilled care or rehab. And home care, I don't know what the copays for those are at this point in time, but there will probably be.
They're not really that high. Again, clients that are on Medicaid, they often get zero or very little copay costs. Same thing with Medicare because they've pretty much paid into it, receiving that. But you'll be surprised that no matter how much they paid into it, how much those costs still have gone up.
I agree because we have done nothing. And you know what? I'm doing investigating in universal health care, and they're imploding right now too. They're not providing the care that needs to be cared for because what our reimbursement has done right now, even for our doctors and our specialists, has caused a shortage because the doctors are not making what they did 20 years ago. And finally the American Medical Association is stepping up and saying, hey, we can't take any more cuts. And what this has done is created people that would be doctors or specialists to go into other avenues of care. And we really are at a serious situation.
Yeah, all in all, I feel like all there is to do is either to just continue funding this model, or they have to start making significant cutbacks into the administrative burdens and the research and everything that is involved. Because even if we talk about prescription drugs, you don't understand like what these companies have to go through to get FDA approval, the research that has to be conducted, the duration, all this is cost over cost that just get more and more with time. So yes, maybe cutting those out is going to make prescription drugs a little bit cheaper. Yes, it's going to make them riskier as a result. But so far, a lot of medications and a lot of supplements have been not evaluated by the FDA, and they've been okay for some part. And not that I'm advocating for the removal of a lot of administration, but I just feel like the over bureaucratic nature around these kinds of services being provided is the reason why we are seeing a decline in quality and the decline overall in the care being provided, because there's just so much bureaucracy around everything.
Yes.
And unless the
and
way
the
that
government loopholes, the regulations. Think about this. Our tax dollars, our healthcare tax dollars have been going to managed care organizations to be gatekeepers. And what do? I feel this is so insulting. Our tax dollars are paying for the businesses, the employees, their benefits, their equipment, their bonuses, their buildings. Our tax dollars are paying for that. And now these managed care organizations aren't happy with the amount of money they've gotten. They have to turn around, even though they're getting huge salaries. The CEOs are getting huge salaries and bonuses. And they're expecting we, the taxpayer, to pay more towards our tax care dollars. They just need to get rid of all those people and put that money really back into our pot.
Just to be very clear, Ms. Diane, how many more questions do we have? Because I have a hard problem.
Honey, okay. Oh. Let's just
wrap it up. Yeah, again, I'm so sorry, but stop.
No, that's okay, sweetheart.
Okay. Start. Start. I will say definitely making sure that the reason this is happening is very clear, because Medicaid, they don't get any money for it. Medicaid is a federal and state program, and they have to pay for audits. They have to pay for administrative personnel to answer calls for the providers and the clients. They have to pay their case managers. So they're not making any money. So for them, Medicaid is a loss business. It's a loss leader. So that's why they require more state funding, because they don't want to invest more money than they already have to. Yeah. So for them, they're trying to make their Medicare models more efficient, so it puts more money into their pockets, just like their commercial plan does, which you pay a premium and you receive care. But Medicaid and Medicare aren't unfortunately like that, because Medicaid they specify a series of funds and it's for that patient. You cannot touch that. So that insurance, so that MCO can't say, oh, they didn't use the care, so I'm going to take this $6,000 and put it in my pocket. They can't. It goes back to the government. So that's why they don't care. If it was up to the private companies, they would end Medicaid and partially Medicare altogether, because it's not a business model they find sustainable. That's why they are under pressure by the shareholders. So these lucrative salaries are a reason for that CEO to keep fighting to make sure that they can make their company as efficient as possible. Because one thing that drives anybody across the face of the earth is money. Because you know the saying, money talks and BS walks.
Yes. Aria, thank you so much for your time today. How do we reach out to you?
So you guys can reach out in various ways. They can contact the office, which our phone number is 703-953-7202. You can also reach out via email at info@ariahhc.com. And they can stay in touch with us through our LinkedIn and Facebook pages and reach out to us if they have any questions or if they're just interested in receiving some information about our service offerings.
To my family caregivers out there, you are the most important part of the caregiving equation. Without you, it all falls apart. So please learn to be gentle with yourself. Practice self-care every day because you are worth it.